Okay, good morning everyone. I'm Dr. Priyanka and hi, welcome. This is our first class and we'll be talking about prosthetic dentistry and the topic for today is diagnosis and treatment planning of completely edentulous patients. So in short, the patients which do not have even. Okay, coming to the learning outcome. So, what does that mean is so by the end of the lecture, you should be able to answer these four questions. Okay, so you should be able to diagnose the given condition in patients effectively, infer the importance of medical and dental history in diagnosis and treatment planning, analyze all possible variations in the oral anatomy during examination, formulate a treatment planning considering the observation made during the diagnosis. Okay, so coming to the clinical history. So, first of all, as you all know, in all the departments, first of all, we um, take care about the personal data. And personal data consists of six things, that is name, sex, age, address, telephone number, occupation. So name is important as you can address the patient with the name. Um, Sex, there are some diseases which are which have a predilection in the female and the male category. Age is important, especially in prosthetic dentistry, as the complete denture patient usually are 50 above. Yeah, so they're 50, 60, 70. Yes, I think even 80. So usually, and there are many age-related systemic disease, uh, systemic disease which are related. Okay, address, phone number is always good for their personal record. So if anything happens, we can refer to those. Okay, so these are basically all the confidential info. Occupation. So there are some occupation hazards which happen, right? So some diseases can be caused due to in some specific occupation, right? So this is also an important detail. Okay, coming to the systemic status. Okay, so conditions affecting complete denture therapy, there are many of them. So starting first with the most important is diabetes mellitus. So diabetes is commonly seen. Patients suffering from diabetes also has osteoporosis, residual alveolar bone resorption. So this is known as RRR, okay, residual ridge resorption, which is very important in prosthetic dentistry to restore and make the dentures. Okay, and how do we deal with them? There are certain impression techniques and you know uh, certain things which we are supposed to do. So this is really important. And yes, because of diabetes there is delayed in wound healing, so they are more prone to infection. So we can see if they have an extraction socket, it's going to take very long to heal. And so things can be related to each other. Okay, in this condition the impression technique which is indicated is mucostatic. Okay, so there are more impression techniques, so definitely we'll talk in detail about this in further lectures. Teeth selection and type of occlusion is also important in such patients. Okay, and we have to avoid any surgical intervention because that would create a problem, and there will be a wound healing issue. Coming to the second one, that is a cardiovascular disease. Patient should be given an early morning appointment to avoid any tissue changes which occur due to medication late in the later part of the day. So duration of the appointment should be short and it should not be so strong. Okay, at least we can try to do that. In anemia, what happens is there is soft tissue overlying bone which becomes fragile, and there's a possibility to enhanced bone loss. So again, bone loss is not a good thing. And yes, there are methods to take care about that in prosthodontics if there is already alveolar ridge resorption, right? So there's a decrease in the denture bearing capacity of foundation tissues, right? So same thing, you will see that there is a loss of the denture bearing capacity. So meaning loss of the ridge, it will be a low resort ridge. Okay, the healing capacity will also increase. Okay, coming to arthritis, some of the clinical features: pain, crepitation, during mandibular movements. Okay, so yes, when they cannot do mandibular movements, jaw relation will be hampered. So a procedure known as jaw relation, restricted movements, tenderness in muscle of mastication in advanced stage, disability, atrophy of associated muscles. So if the muscles don't work, the patient won't be able to really masticate and chew well, or he will have a less decreased ability to do any of the functions. Okay, difficulty in wearing and cleaning dentures. Okay, impression making and jaw relation will be definitely difficult. Okay, frequent occlusal corrections may be required because as he will not have a stable occlusion, as he might keep having some resorption, and he might not close in one direction properly. Okay, coming to the neuromuscular disorders. So these are the conditions that can improve um, yeah, sorry, so these are the condition which will improve the by advocating neurotropics, because the patient's neuromuscular coordination would not enable to do a proper jaw relation. Okay, so jaw relation is a procedure where we record the relation from maxilla to the mandible. Okay, and also to the cranium. So it's there are three types of jaw relation, guys. Okay, I'm not going to get into detail of that right now, but those do need a neuromuscular coordination, yeah, and that would be hampered. So these are some enhancers which will help in relieving this disorder, yeah. Okay, so vitamin B6 and B12 should be administered. Okay, so any secretory activity is reduced, affecting the defense mechanism of oral tissues. Okay, so these things will not work well. That's why it should be reduced. Okay, I mean that's why it will be reduced. Yeah, because of the disorder. Okay, patient undergoing radiotherapy. Okay, so osteoradionecrosis and necrosis of the soft tissue is commonly seen, and of course it's contraindicated, right? Posterior occlusion should be such that it's reduced stress, and there should be a flat occlusal table. So if you have a flat occlusal table, so there are some teeth which is known as monoplane teeth, monoocclusion. Yeah, so those are teeth without any cusp, and they are more flat. Okay, so those will be the ones which are indicated here. Just reduce the stress. Okay, coming to the dental history. So you need to know the reasons of the tooth loss. So what are the reasons, the periodontal caries or any other causes? Okay. Uh, so we can know if there is one teeth remaining, or if there is something, what what is the possibility of it also falling off in this region? You understand? So you can know, I mean, definitely can at least ask the patient. Okay, previous denture experiences. This is very important in the old denture wearers. So first of all, it's a little difficult to deal with these patients because they have a denture in certain manner which they are wearing from 10 years, 20 years, 30 years, and suddenly it breaks, or there's wound resorption, and they expect you to make exactly the same denture, and then things get complicated, and then so to take care of patient expectations is a little difficult, but if you do a good job, they will definitely be convinced. Okay, so first of all, you have to have a chief complaint in the patient's own language. Duration of the wearing of old denture should be written. So information about the aesthetics, the phonetics, mastication, retention, everything has to be asked. Aesthetics is the way it looks, phonetics is the way they were able to speak, mastication is the um, way they eat, retention is the fit of the denture. So vertical dimension of occlusion and centric relation also can be seen if they have it. Okay, so you can also watch that. Coming to the evaluation of mental attitude. So first of all, the divan statement. So this is a very famous statement. If you want to meet the mind of the patient before the mouth of the patient. So once you get into the mind, you understand many things. So Dr. House classified the mental attitudes into philosophical, exacting, um, indifferent, and hysterical. So these are the very difficult patients. Uh, Physiological uh, um, is the one which is the ideal one. Okay. Okay. So the philosophical patient is the one which is the very ideal patient, learns to adjust rapidly. So he has rational, he's sensible, calm, composed. Okay. He would understand how to overcome conflicts. Sorry. He would organize his time, habits, manner, eliminate the frustration. If you explain something, he'll understand. Exacting patient will require extreme care, effort, patience, so little on the difficulty level. The patient is, a little precise, accurate, and has several demands, and then need to understand. And the patient is intelligent and will understand, and he will give his time. But then you have to make him explain a lot of things and just many things. Okay, indifferent patient is very questionable, unfavorable, favorable prognosis, so will not understand a lot, exhibits little concern. He's uninterested, less motivated. He pays no attention to your instructions, does not cooperate, blames the dentist. So, um, yeah, this is a problematic patient. Okay. Okay, so like an educational program is required for this patient to teach this patient. Okay, hysterical patient is like an emotionally unstable, excitable. So he's very extreme in everything. Understand, he's basically unstable, and prognosis will he will have an unfavorable, and he'll require some psychiatric help if he's not cooperative. Okay, so this type of patient should be made aware of their problems, and there are many of his symptoms will result in having problem with the dentures, or having problem with the treatment plan you're going through. Okay, so these are difficult to um, handle. Okay, coming to clinical examinations, coming to the extraoral first. So you can see you have to know the shape of the faces. This is the square, this is the tapering, and this is the ovoid. Okay, so why the shapes of the faces are important? Because they help us in the teeth setting and teeth selection. I'm sorry. Okay, so uh, the squarish will have more of a squarish sort of teeth. The tapering will get a little tapered one. Okay, so these two, and they will have a little bit oval, and also depends on male, female. Okay, so same with this. Okay, so these are the curvature of the teeth. Yeah, how would they be concave, flat? Okay, so it is a little important in the teeth selection, which you, of course, you'll get to read in detail. Okay, coming to the facial profile. So your angles classification is there: class 1, class 2, class 3, normal, retrognatic, prognatic. We'll discuss it in detail later. Facial symmetry is also important: symmetrical, asymmetrical. So many times when we are recording the frenum, sometimes the facial midline doesn't coincide with the dental midline. Those things come into play. So yes, these things are very, very important. Facial height, normal, decreased, vertical dimension increase. So yes, if there is a collapsed appearance, that means the vertical dimension decrease, especially for patients without teeth, right? Old patients, edentulous patient. Increase means taut, like stressed out and strained. So long faces. Okay, so you can judge like that, but of course there are methods to record the vertical dimension, and of course we use that. Okay, so facial muscle tone, normal, flabby, or a spastic. Color of the eye, complexion. So basically, these two help us in the teeth selection. Okay, yeah. Uh, the facial muscles help us see and appreciate the jaw relations. So we can see how the muscles are reacting to the dimensions we have measured. So this is important. Okay. Coming to the lips, lips is also really important, right? So lips thickness, thin, thick or normal, lip length, long, normal, short. Yes, so lip length is really important because it either it hides the denture, exposes the teeth, suitable, like sustainable, um, like enough. Yeah. Short is that it becomes visible only while slight movement. So these things have to again be checked in the trying stage and in the jaw relation stage. How much is the where is the smile line, and how much there is in buccal exposure, yeah, in the maxillary denture. Okay, so yeah, fine. Sorry. So here, like I can say, the face is all this helps in the selection and the arrangement of the teeth. Okay, yes, and then it will definitely help you in the arrangement of the teeth. Okay, so TMJ troubles, sorry, the TMJ joint. So if there are troubles in the TMJ, pain, opening movements of the mandible, tenderness, clicking sound, crepitation, deviation, muscle tenderness, limitation in mandibular movement, this will really help us in this will not help us in the jaw relations, which is a centric relation, which is one of the part of the jaw relation, which is very important. So the centric relation basically depends on the structural functional harmony of the osseous structures, the intra-articular tissues, and the capsular ligaments, right? So this will be hampered if there is a. Okay, so coming to the examination of the TMJ, so you put the bulk of your index finger, place in the external auditory meatus, and equal pressure is applied while instructing the patient to open and close. Yeah, and then you can see and feel if there's any pain. Okay, that would indicate the abnormal condition. Also, auscultation. Okay, coming to the intraoral examination. So these are the arch. Okay, so this is the arch form. So either it's a U shape or either it's a V shape. Okay, coming to residual ridge form. So these are the intraoral examination, guys. Okay, so this is the Atwood's classification, class 1, 2, 3, 4, 5, and 6. Okay, like that. Pre-extraction, post-extraction, high, well-rounded, knife edge, low, well-rounded, and depressed. So this is basically like the resorbed one, okay? Resorbed and Goodrich, okay? Sorry. So we get variation of these cases in our anyway know the ridge relationship, understand? Okay. So that'll help us to arrange the teeth, guys. Again, yeah. Coming to the inter-arch distance, so there's adequate, excessive inter-arch, inadequate. So 16 to 20 mm is adequate, and excessive is that it has got resolved because of the residual ridge resorption. Then there's a long inter-arch space, and which will lead to poor stability and retention also. Inadequate spaces, there's some mechanical interference. Okay, sorry, yeah, okay. Going to class 1, class 2 very resolved, and class 3 hardly any space. Okay, so this is the ideal one. Coming to the undercut location, so undercut in prosthodontics are also friends and foes. So guys, these are enemies that sometimes they won't let you issue your dentures, and when you have to insert the RPD in the patient's mouth or a CD in patient's mouth, there will be a problem. On the other hand, sometimes they also give you retention, guys. So yes, it goes both the ways. Bony irregularities you can take care in the pre-prosthetic surgery, which comes under mouth preparation, guys. So these bony spicules, again, when you make a denture, they will hurt the tissue and the patient, so you cannot put a denture on top. So you need to relieve all the irregularities. Okay, retained root pieces is a complete no-no. You cannot have these will create infection and create problems. We need to get all these things extracted and then do a case. Oral mucous membrane, it has to be properly examined for inflammatory lesions, any hyperplastic or displaceable tissues, any pathological lesions, oral malignancies, any hyperplasia, any ulcers, any Ebulis fistratum. So these details definitely you'll be reading in your OMR department, guys. Okay, so anything relating to the oral mucosa, everything needs to be perfectly fine before we do prosthodontics, guys. Okay, this is like an overgrowth of the gingival tissue. This is a bony spicule, guys. This is retained roots. This is more like a flabby tissue. Okay, all right, guys. Okay, coming to the palatal vault. Okay, so palatal vault basically is the curvature of the maxillary palate. Okay, also called as the hard palate, right? So this can be U-shaped, sorry, U-shaped, rounded, U-shaped, and V-shaped. Sorry, guys. V-shaped, rounded, and U-shaped. Okay, three types, guys. Yeah, basically, most commonly seen as the U and V types. Uh, yeah, U type is most suitable in reference to retention and stability, guys, whereas V causes deflective force and very hard to get retention, guys. Okay, in recording the PPS, the posterior palatal seal for the retention of the maxillary denture, guys. Coming to the maxillary tuberosity, these are normal and larger pedunculus, which is like uh, what do you call this is a hanging, like a hanging tuberosity. Okay, coming to saliva, saliva is very important, guys, in the retention of the denture. Without saliva there's no retention, guys. Okay, so it forms a seal between the denture and the palate. It's sandwiched inside, right? So the normal and amount and viscosity is favorable. Thin watery saliva is best in theory, but a mix that includes some viscous saliva will provide best retention, right? So guys, in the denture issue stage, this is really important. Okay, thick ropey saliva complicates the impression making, and obviously, yeah, it annoys the patient. Yes, so it works both the ways, but having a good saliva retention, excessive saliva is also common when the patient is first. There is insertion of the denture, but because they don't understand the mechanism of swallowing, guys. So when we have teeth, we know that we have to swallow. They will not understand that they need to keep swallowing. So once they swallow, these things improve over time. Okay, so deficient saliva xerostomia in geriatric patients, there's systemic disorders, and because of them taking medications. So this may be a problem. So no saliva results of radiation or oral cancer. Okay, so real xerostomia is a big problem. Okay, so guys, tongue, coming to the tongue. So tongue size can be classified into normal, abnormal, large. Tongue position, so Wright's classification, class 1, class 2, class 3. So the tongue lies in the floor of the mouth with the tip forward and slightly below the incisal edge. Second is the tongue flattened and broadened, but the tip is in the normal position. So retracted, depressed into the floor of the mouth with the tip curled upward. Okay, so we can see class 1, class 2 is the normal one, and class 3, guys. Frenal attachment can be normal, close to the crest, or broad. So this is very important when we are having our border seal and also while recording the impression. Yes, so this comes into play, all right, for both maxilla and mandible. And sometimes these are very prominent, sometimes these are not prominent. Okay, so labial frenum, the buccal frenum, right? Okay, coming to the tori here, guys, what I've noticed is I've not seen more toris before. So every other patient who comes, so it's very prevalent in this part of Malaysia, I guess, or in Malaysia. So uh, this is very commonly seen, especially the Taurus platinus, okay, platytinus. So this is in the maxilla, and mandibular torus. Also, I've seen in a few cases, maxillary tori is very common. So does not require surgical intervention unless large and bulbous. No, they are not really large and bulbous, but yeah, they are there. So sometimes you can make like a roofless denture. That means like a horseshoe shaped denture. You can cut out the uh, what do you call it? You can cut out from the PPS and make it like a horseshoe shape, like a U-shaped denture. Sometimes you can also, cover the torus up, and it will also aid in retention, guys. So we have done both the things and both work fine. Okay. All right, so mandibular torus usually more of a problem. It interferes in the lingual bars. Yes, guys. So this is more a problem, but this is really I have not seen this commonly, so it's fine. Surgical correction is indicated if it's very prominent. Otherwise, especially if there's a lot of undercut. So I told you, undercut cut can go both ways. So this is the posterior lingual area, which is known as the retromyloid fossa, and it's important for the stability and the seal, the peripheral seal. Okay, so Neil had classified into three types. So class one is when you put a mouth mirror, it is not visible when the tongue is in a slightly protruded position. Class two, one half of the mouth mirror is visible, and which is less favorable. The entire mouth mirror is visible, which is the least favorable. So usually it's class one, guys. Usually, yes. Sometimes it's class two, but you have methods to deal with that. Yeah, yeah, guys. Okay, so this region on both the sides, guys, both the sides. Okay, this is a mandibular edentulous cast. This is the ridge, guys, and this is the cast. Okay, this is the base, right? And that's the retromylohyoid. Okay, coming to special investigations, so there are radiographic investigations which can be done. Panoramic radiograph is known as an OPG, guys. Okay, can be done. So why do we do it? We can do it to study the residual ridge resorption, RRR. We don't usually do it, guys. I rarely advise patients to do it, but yes, in severe cases where I see a lot of problems, I do tell them to do it. Okay, radiographic examination of bone density by mesh. So yes, bone density can be measured. Okay, so mesh has written implant textbook. Okay, so bone density can be measured. He's the author of the implant textbook. Study of location of anatomic structures. Yes, of course. So these things can be studied in radiograph only if required, guys. That's why these are known as special investigation, not required usually. Only if required. Diagnostic cards only cast only if required. So we take an impression just like a study model or a study cast or a diagnostic cast. Okay, these are the three different names. It aids in the evaluation of anatomy and relationship in absence of the patient. So if we can study and see how the ridge is, where is the frenal attachment? Is it even visible? How deep is the arch? Um, where is the PPS? If we can, see. Okay, so it helps in evaluating. Sorry, yeah, these things. Ridge relationships, confirm clinical findings, measuring, determining relation of other structures, decision about pre-prosthetic surgery, undercut surveying. So everything can be done. Okay, so it's like a study model, a study cast. Pre-extraction record. So yes, this is very important if the patient has it. Okay, so usually we don't do this. I mean, we just see old dentures of the patients has. Yeah. Okay, so it can be done. It's a very good method. So photograph showing the natural teeth, how their natural teeth was, old radiographs if they have any, diagnostic cast radiographs obtained from other dentists. So again, this is something which no one really brings, guys, but it can be done. Okay, existing dentures is the best method which we usually use. So the impression of the patient's existing denture taken and diagnostic cast, of course, um, we can take a model of this and keep it with us, and also check the vertical dimension, the centric relation, the centric occlusion. Okay, these are all the jaw relation things can be checked. Other investigative procedures, so to rule out diabetes mellitus, patient's BP has to be recorded. Okay, the hemoglobin level has to be checked, intraoral, extraoral, any biopsy advised histopath examinations. And these are the other investigations which can be done if required by your geriatric patient. Okay, so treatment plan goes as follows. So it should be like specific, specify regarding the treatment procedure, operating time, lab time, fees. Everything has to be informed. Consent regarding the same has to be obtained. You have to explain the patient beforehand how much how many times does he have to come, how much does he have to pay, how much is the amount of time which all the appointments will take. Okay, everything has to be explained to the patient. Okay, so completely edentulous patient, the adjunctive care, patient education and motivation is required, of course, and it has to be, educated about the same. Elimination of infection, elimination of pathosis, treatment of abused tissue if required, tissue conditioning. So you'd use tissue conditioners here, guys. Of course, we'll learn about that in detail. Nutritional counseling if required. So all these has to be taken care of. In prosthodontic care, conventional complete denture, implant supported complete denture. So this also has to be informed to the patient. What are we planning out in the prosthodontic care? Adjunctive care, guys. So in patient education, you can teach him about the dental health and treatment outcomes. You can tell the limitation of a complete denture and why maybe he should get an implant supported overdenture or instead. Yeah, problems associated with dentures initially, and then how it helps improve. Importance of oral and dental hygiene. So dental hygiene after the denture is very important, guys. Okay, so dental hygiene instructions are very important. They are given. Need for regular checkups. So also convincing the patient to do treatment procedures such as surgical treatment if required, motivating the patient, diet counseling. Okay, so and also if required, refer to a dietitian. Why, guys, you are hearing too much nutritional diet in this lecture? Because these are geriatric patients. These are very old patients who don't have teeth, so they're not chewing well. They're not eating half of our nutritional requirement things. You understand? So that's why we are having this thing as we're and emphasizing more on diet and nutrition. Okay. So there are now non-surgical and surgical methods to treat abused tissue, guys. So resting the denture, supporting tissues is one method. Regular massaging is one method. Occlusal correction can be done. Establishing a vertical height, refitting the denture. There are drugs to eliminate infection if some redness, something happened. Nutritional supplements. Okay, so these can be seen maybe after the issue or before the issue. And these things can be taken care of regularly. Okay, surgical method, guys. Okay, so a correction of hyperplastic ridge tissue. So that's like a flabby tissue which is present in certain combination syndrome. So um, we of course will read about it in detail in other lectures. So flabby tissues can be taken care of. So um, also we can take care of this papillomatosis. Okay, so papillomatosis is guys, these are dermal papillary papilla overgrowth, guys, which can be taken care of. Okay, yeah, so these are basically the uh, sorry, guys, these are like the projection of the dermal um, papilla, which is like above the skin surface. Okay, which can be taken care of, guys. Okay, coming to the Epilis fistratum. So these are like the benign fibrous connective tissue. Okay, so these are basically the overgrowths, like the gingival overgrowths. Yeah, which has to be taken care of. Also, coming to the fourth one, that is the hyperplastic pedunculous tuberosity. So here, this like an overhang tuberosity. Okay, so which also has to be taken care of. Okay, so indications are no response to non-surgical, obviously. So if non-surgical don't work, then the surgical has to go through. Okay, so it interferes with stability. That's why it has to be taken care of. Okay, frenal attachment. So there's maxillary label frenal attachment. Okay, and okay, so that has to be taken care of. If lingual tongue ties there, prominent buccal freni, so those things have to be taken care of. Okay, indications if it's really near to the crest of the ridge where you really cannot record, and exert too much pressure on the ridge surface, because we are going to place the ridge and the denture on the ridge, you understand? So cannot be really at the edge. Okay, so frenectomy is indicated for such cases. Okay, guys. So coming to, I think, my last slide, which is surgical methods. Okay, so for papillary hyperplasia, these are the small lesion is sharp, you know, can be seen on the red small lesion seen on the hard palate, guys. Yeah, so it can be taken care by electrosurgery. Large lesions, split thickness, supraperistal flap can take it up, okay, if they're large lesions. Vestibuloplasty, it restores the ridge height by lowering the muscle attachment and attached mucosa. So only if indicated, guys, we get the patients do this. Usually none of it is indicated. It's commonly seen as like the bony spicule, which has to be like like alveoloplasty basically, and also extraction of the hopeless prognosis sheet, that's like the class 3 or the root stumps, and then waiting for the healing periods. That is mostly seen in our department. All right, guys. So thank you so much for patient listening, guys, and hope you understand the lecture. So now I think every Thursday we will be having a lecture. I'll see Tuesday, Thursdays, whenever. So guys, please let me know if you have any questions, guys, and you can come and see me on the prosto floor on the level 20 in the polyclinic 3. I'm always around there, guys. So guys, you can come and see me, and any questions, please read and let me know, guys. Yeah, thank you.